Hi, everybody. Thank you all for joining this Rupa University webinar series. My name is Dr. Jonathan Stein. I'm the laboratory director for SpectraCell Laboratories. And I just wanted to discuss some of the tests we have on offer and what their advantages, why you'd be interested in learning about nutrition and longevity and heart health and more. Buckle in and let's get started. Let's see. So to begin, we have 4 core tests. I'll go over them in more detail. We have a micronutrient test, which is a functional test for nutrition, which is really fascinating. And there's a lot of bits to it. So I'll go to that in a little more detail. I'll talk a little bit about LPP, like a protein particle profiling, that test, and why your cholesterol test may not be giving you the information you need. The telomere test, SpectraCell was one of the first laboratories, I think the first laboratory, non-academic laboratory to perform commercial telomere testing, what those are about and what they can tell you about, and MTHFR genotyping. Now, those 4 tests, nutrition, lipoprotein, cardiovascular health, telomere testing, and MTHFR, those get spliced and diced in different wellness panels. We have panels for your immune health, for your mental health, for energy optimization, for weight optimization, tests associated with all these that can tell you a bit about biological age management, cardiovascular risk management, and again, monitoring GLP-1 response. And of course, there's what's called baseline nexus, which is all of the tests. So you can get all of that information, which is a lot. So let me go into it. Just to focus the mind, I almost always start at most of my presentations with one of the most recent CDC numbers for the top 10 causes of death. You can see here, heart disease, cancers, pulmonary disease, strokes, Alzheimer's disease, diabetes, assorted cancers. What you can see about all of them is they tend to happen later on in life, which tells you that these diseases are diseases of aging. Some happen later in life, and the later the better, of course. We want them to happen as late as possible and ideally not. And again, aside from accidents, a lot of them are also associated with immune response. There's a lot of science showing now that inflammation, which is essentially your immune system's response to something, a biological provocation or what's called an environmental insult, can have a big impact on how long somebody is sick and how severe it is. It's now very well known that there's an immune component, that your immune system is constantly hunting down and killing small cancers before they become big cancers and before they mutate and deregulate enough that they can evade the immune system. Alzheimer's disease, again, infections, obviously lower respiratory infections, essentially pneumonia. We're looking at chronic infections. And so all of these diseases, you will find there is an immune component. So we want your immune system to be as healthy as possible so it can address these challenges. And hopefully, so that if you do get any of these diseases, again, the 10 most common in the US that lead to death, that it happens as late as possible or not at all. I want to start talking about the micronutrient test now, and here's why it's important. Nutritional intervention can be a critical component of disease prevention and an important aspect of disease management or the primary treatment for some diseases. Nutrition is important. But here we measure the nutritional status of your immune system, of the T cells, the sort of generals of your immune system. So we're trying to find ways to use nutrition to maximally optimize your immune health with the assumption that if you have a healthy immune system, that'll help the rest of you as well. Suboptimal vitamin status is associated with many chronic diseases, including cardiovascular disease, cancer, cerebrovascular disease, stroke, and osteoporosis. And repleting these deficiencies have been reported in many scientific clinical publications to either delay the onset, reduce the risk of getting the disease at all, or reduce the severity of the disease. So the technology we use is from the University of Texas Biochemical Institute, and they had done a previous study through the Clayton Foundation showing that people without supplementation often had 38% of people without previous supplementation. So people who aren't taking supplements, about 40% of them, 38% of them had multiple nutritional deficiencies when you throw them on a micronutrient panel, when you look for their functional deficiency status. People with previous supplementation, also, again, about 40% of them. So there's a couple ways to think about this. We're not trying to oversell nutrition, right? It's not a magic bullet, but it can really help improve the quality of someone's life. A lot of people will read, oh, here's the benefit of this, I should take this. Here's the benefit of that, I should take that. And eventually they're taking a wheelbarrow full of supplements, some of which they need and some of which they don't. And all of them are interacting in complex and unpredictable ways in the body. Here, we'd like to help you target, do precision nutrition, identify the things that you are deficient in, and address them. So we measure function. And I'll go into a little bit of detail of what functional nutrition means. The way we perform the testing, it's pretty straightforward. We take the patient's nucleated cells, we put them in a chemically defined media, so we know everything that went into it. There's no fetal bovine serum. It's all made from chemicals in-house. We grow them in this chemically defined media where we know everything that went into it, and we change it by exactly one nutrient. And we do this in triplicate on 296-well tissue culture plates. So we're doing all of them at the same time in different tiny petri dishes. Sort of is a way of thinking about it. And we ask a simple question: how well do your cells grow in the presence or absence of a nutrient? For example, we grow the cells in the presence of B12. It's in a nutritional solution that has it. And then your cells have to grow in a nutritional solution that doesn't have B12 in it. And so your cells only have their own intracellular stores of B12 to grow with. Now we stimulate the patient's T lymphocytes to grow and divide. And we ask the question, do we see a significant change in growth under the two conditions? That is to say, when the cells only could rely on their own vitamin B12, did they have enough, or are they really struggling? Do we see a significant decrease in the rate of T cell growth and proliferation? And we interpret that as a functional deficiency. That is very different from blowing up cells and counting the number of B12 molecules inside them. Every patient is unique and has unique needs. And the ability to precisely say, this is what the patient is deficient in functionally, is a huge step forward in treating their health through nutrition. So function encompasses diet, right? Or the ability to synthesize those nutrients, the gut absorption of those nutrients. Then they're going to be floating around in the serum, and then they get absorbed by the cells, right? They store those nutrients and they mobilize those stores, and then they utilize those stores. And there's a certain amount of recycling going on. And that is not the same thing as counting molecules. Conventional nutritional testing tells you nothing how they're being used. At best, it tells you about gut uptake and synthesis. And to give a simple example, about 1 in 6 people of European descent have a vitamin D receptor variant. It's a naturally occurring genetic variant that makes it a little less efficient for them to absorb vitamin D. Because of that, and this is a cellular receptor. So because of this, they have trouble getting vitamin D into their cells, which is where vitamin D is used. Your body doesn't use vitamin D outside of cells. For those people, because they have trouble getting vitamin D in their cells, they tend to have more outside of their cells. So if you did a serum test for vitamin D for these people and a functional test for them, you'd know they'd be having trouble functionally getting vitamin D in their cells. But if you look at serum, they might have higher than normal serum levels. Again, because they're having trouble getting them in their cells. And that shows some of the advantage of measuring function. The other thing that's interesting is because we're looking at stores, it's a long-term measurement of nutritional status. And not to belabor this slide, there's just a lot of cool information on it. So again, I had a roommate who on some weekends, this is back in college, I had a roommate who on some weekends, he would run marathons, and some weekends he would pig out on Ben & Jerry's. And as you might imagine, if you did a nutritional test after Ben & Jerry's weekend, it would look very different from a serum nutritional test after the marathon weekend. But maybe it is more useful to take a long-term measurement. What are the nutritional needs of somebody who sometimes pigs out on Ben & Jerry's, sometimes runs marathons? And so that is another advantage of functional testing, right? Again, because it takes for antioxidants, maybe 4 to 6 weeks for that cycling to occur. For a lot of other nutrients, it can take 4 to 6 months for that cycling to occur. But if you look at serum, that you take a vitamin, it'll float around in your serum for 8 to 72 hours before whatever doesn't get absorbed gets filtered out. So in one case, you're looking at a snapshot. What has your nutritional uptake been for the last 3 days? Where function can say, what is your nutritional utilization for the last 4 to 6 months? And then finally, again, because we're measuring T lymphocytes, we're measuring immune system health and the nutritional needs of your immune system. And that is important for overall well-being in a big way. Again, I apologize, this slide is super noisy. Let me just say we are measuring T lymphocytes. We look at about 31 different vitamin and minerals and amino acids and fatty acids, right? We look at how well your cells can grow when they're growing in an optimal media. So that gives a sense of we call it immunity, it's a test for overall immune system health. Very similar to a historical test called an LPI, lymphocyte proliferation index, if you guys are familiar with that. And again, the precision extends beyond the short-term blood serum measurements. So again, correcting these deficiencies is important to overall health. We talked a little bit about T cells. Here's why T cells are important and why they might be an advantage over other cell types. In most patients, again, it's easy to collect, it's easy to ship, so that is lovely. And we use a T cell specific growth stimulant to measure their growth and proliferation modes. So unlike many other cell types, T lymphocytes have complete protein, carbohydrate, lipid, and nucleic acid metabolism. They're nucleated, they have their own DNA, and they share many of the housekeeping genes, about 50% of the housekeeping genes with the rest of the cells of your body. That's helpful in terms of function. There are some competing tests that use erythrocytes, so red blood cells, but they're non-nucleated. They're a hyper-specialized cell type, and so they may not be that good of a proxy for overall function, just because they're such a specialized cell subtype. Again, T lymphocytes are generals of the immune system. They play a key role in cell-mediated immunity. The ability of your T lymphocytes to respond is very crucial to health, right? You want your sort of immune system to be able to rapidly expand, to very quickly respond to inflammation, or to very rapidly respond to immune challenges. Okay. And again, we used animal models to show that if you feed mice, this research at Rice University showed that mice were fed diets specifically depleted for B vitamins, the mouse lymphocytes would become functionally deficient. So we know from animal models, couldn't do this in people, shouldn't do this in people, but we know that this sort of thing can be reversed and you can supplement in B and restore that function. Next slide, please. So micronutrient test units differ from other labs because in many cases, they are blowing up cells and counting molecules. And so that could be measured in micrograms per microliter or nanograms per deciliter and so forth. We are measuring percent changes in growth. So because we are measuring function, the function we are measuring is the difference between if a cell is challenged to grow with its own nutrients or if it has all the nutrients it needs. So between those two, we can measure the functional requirements for any given patient's cells for any of the nutrients we test. Next slide, please. So again, and I think I covered this, but I'll just do a quick summary and we'll move on. There's a really big advantage to this particular approach, or there's a number of different advantages. It's direct measurement of micronutrients in living cells. We're identifying sort of precision nutritional needs. We can measure the cellular function in T lymphocytes, which are important in and of itself, and a lot of other methods do not measure function at all. Or if they do, they're measuring it indirectly and making inferences. We measure our measurement has a larger pathway component. Again, we're measuring gut uptake, synthesis, cellular uptake, cellular storage, mobilization, utilization of those stores for growth. That's not going to be captured in a wide variety of different competitor methods. It's a larger window of nutritional balance, use versus intake versus output. And that's not necessarily going to be the case for shorter term assays. Immune system is important, and that's not something that a lot of people are testing. We also measure total antioxidant function, which lots of other people are not measuring, but it's important. How well your cells can survive a oxidative challenge is important. Some people have jobs that put them under lots of oxidative exposure, and they're going to want to have as much resistance to that as possible. Again, we measure the T cell growth response challenges, other people's don't, and we measure this biochemical individuality, which is not necessarily going to be assessed by a one-size-fits-all nutritional strategy. Next slide, please. Put up a couple of slides that we have that just show how different nutrients play into many common health conditions and to show that there's a wide, so one, we measure a lot of things. Those things can be important for a wide range of health conditions and that they can give you a lot of information you need to help improve those conditions. So hypertension, again, very common. Next slide, please. Weight management, also very common and amenable to some nutritional strategies. And finally, sports nutrition. So we have tested in the past and present many different professional athletic teams who are interested in optimal performance. So you have on one side, you have patients, and we've certainly treated folks who had metastatic cancer and they wanted their body and their immune system to be as strong as possible to try to fight off that issue. And we've also got people who are doing sports or in extreme health. We've got people who are looking for wellness and weight management, and we've got people on the other side of the coin. Next slide, please. Forward, please. Next slide. Thank you. Moving on towards heart health, we also have a very advanced lipoprotein particle profile test. And what makes it advanced, it's a super interesting strategy. So it turns out 50% of people that have a heart attack have normal cholesterol, less than 100 milligrams per deciliter. This comes out of the Framing Heart study, which is a longitudinal study that's been going on since 1948. So we're heading towards 80 years of longitudinal testing of this group, and the multiple risk factor intervention trial, it's got over 350,000 people. And what this points out is that standard cholesterol tests do not identify thousands of people that are at high risk for cardiovascular disease. Why are standard tests misleading? Advance, please. Next slide. I will talk you through it. So it turns out a real disconnect. Cholesterol is very easy to measure, but it's a very indirect measurement of what's going on. You've got these lipoprotein particles, which are the actual problem. And what they do is some of them are small enough that they can get inside what's called your arterial intima. The linings of your arteries have these little pores in them. And occasionally lipoproteins get stuck in them and they get inflamed. And that causes a scabbing process that eventually builds up and becomes atherosclerosis. It eventually starts arterial blockages, right? The standard cholesterol test works by blowing up the lipoprotein particles and measuring the cholesterol content inside. That is not the issue. Like cholesterol is the carrier of the lipoproteins, but it doesn't itself play much of a role in terms of causing plaques and heart disease. Next slide, please. So again, it's the lipoproteins that cause harm, not the cholesterol that's being carried around. The other issue is that these measurements assume that everyone has the same cholesterol in their lipoproteins. It's just not true. It varies by person. And some people can be depleted of cholesterol, some of them can be enriched, and those have very different outcomes clinically. Next slide, please. There's a great example slide. I think we're coming up on it. So again, if someone's cholesterol is low, so it's cholesterol depleted, that underestimates the risk. If they're enriched, it overestimates the risk. But again, it's really about those particles. This is particularly common in folks with high triglycerides, so people who are on paleo diets or high fat. I'm told lots of my friends have told me stories when they went on paleo that their doctor did routine cholesterol testing and it doesn't look great. Next slide, please. But that again does not capture health. There are lots of different ways that you can have variation in cholesterol. There's variability in core composition. Some of it's genetic and some of it is dietary. And there can be variations in particle size. So when LDL is cholesterol depleted, it can undergo structural changes and become a smaller, denser particle, which creates different LDL particles depending on what's going on. So it's a kind of a complex process. Standard cholesterol tests can be very misleading. Next slide, please. You can have healthy forms of HDL. You can have unhealthy forms. You can have healthier types of LDL as well. Next slide, please. Here's a great slide that kind of illustrates this point. You got 4 people, Jerry, Susan, David, Maria. They all have the exact same amount of cholesterol, 125 milligrams per deciliter, but they have extremely LDL content. One of them's got large buoyant LDL, and that means that it's not going to get into that arterial intima and cause atherosclerosis. It's too big to fit, like trying to get a basketball into a golf. But Maria, unfortunately, same amount of cholesterol, but her LDL is small, dense, depleted. Very easy for it to get into the cardiovascular intima and jam things up. So she would be at high risk. And that is the sort of, and so that second level of analysis, going beyond cholesterol and looking at characterizing someone's lipoprotein particles, doing that kind of sizing, density measurements, is what the LPP panel is about. Next slide, please. So the National Cholesterol Education Program, whose goal is to reduce heart disease and determine the best course of treatment, they have cited emerging risk factors above standard cholesterol testing, measuring for small dense LDL, lipoproteins, measuring HDL2B and lipoprotein, and the LPP measures all 4 of those emerging risk factors. Next slide. So that's to get you the most accurate amount. So I think I mentioned this, small dense LDL can easily penetrate the arterial endothelium and cause plaque. The size and number of them are really important, right? So you want to know, like, how small are they? That's how easy they can penetrate the arterial endothelium. And if you've only got 4 of them, that's not so big a deal. And if you've got 400 million of them, that's a real problem. So we measured both those things. So remnant lipoproteins, it's the building block of plaque. Lipoprotein it's easily oxidized. So it's very easy to inflame the system. And again, it's a marker for how well cholesterol is being cleared out. Next slide, please. Why it's important is because they can be treated, but the treatment depends on the risk factor, right? And if you turned out you had 125 milligrams per deciliter of cholesterol, that would tell you nothing about the most effective treatment here. Right? Statins don't lower RLP or LPO, but those can be amenable to niacin cysteine, CoQ10, vitamin C, and omega-3 fatty acids. So here, this can guide a more effective treatment. Next slide. Oh, and we got to get going. Terribly sorry. The other thing to know is that statins have side effects. So if you're on them, then you might want to get your micronutrients tested. And also, if there are alternative treatments to statins, or if your high cholesterol might better be served by finding out the underlying particles and addressing those issues, that could be helpful as well. Next slide. Here's a quick case study of a patient who was prescribed Lipitor prior to LPP, developed muscle pain. The doctor suggested an increase in statin dosage based on the standard lipid test. We did an LPP that identified that the patient had elevated remnant lipoprotein, small dense LDL, so the atherogenic phenotype. Again, something that you would want to address. They had a deficiency in CoQ10, most likely caused by the ongoing statin treatment. And also they had an ApoE. They were heterozygous for the ApoE polymorphism. So she had a genotype that tends not to respond to statins. So the therapy that was suggested by all of these tests was to take high dosages of omega-3 fatty acids. 2.5 years later, she has a non-atherogenic profile. Her total cholesterol is normal. Her RLP is normal. Triglycerides are normal. And the statin dose could be reduced. So getting the accurate information can lead to better outcomes. Next slide. All right, move right along. We also perform telomere testing. Telomeres are long-term markers of essentially cellular wear and tear versus repair. They're these long strands of repetitive DNA at the ends of all of your telomeres. The analogy everyone uses is they're like shoelace protectors, basically. Every time your cells have to divide for any reason, wound repair, inflammation, growth, wound healing, anything like that. Every time cells have to divide or replacement purposes, your telomeres get a little bit shorter. And once they reach a sort of a critical shortness, once your telomeres are below a certain length, then the cells go into a state called senescence, where they are not allowed to divide anymore. So short telomeres are a brake on cell proliferation. Next slide, please. So this is thought to be a brake on uncontrolled proliferation. So it's thought that telomere shortness is an anti-cancer mechanism to prevent cells from growing out of control. However, there's two things to say. One, you've got an enzyme called telomerase, and it can repair telomeres. So you've got this, your average telomere length being a measurement of wear and tear, cellular wear and tear versus repair. What gets interesting is there's something like now 25,000 papers where anytime they look at a condition, shorter telomeres are associated with worse states. So short telomeres are linked to hypertension, diabetes, obesity, atherosclerosis, vascular dementia, heart disease mortality. About the only thing on the list of the top 10 things that kill you that it isn't is accident. Again, wear and tear is what makes these shorter. There's also significant or borderline associations between telomere and glucose levels, insulin, blood pressure, arterial thickness, the inflammatory markers. Basically, again, it's wear and tear versus repair is going to determine your average telomere length. The more wear and tear you've got, the shorter they're going to be for whatever reason, for diseases, chronic infection, chronic inflammation, anything like that. And then there are things people can do to promote the repair of them as well. Next slide, please. Varies by gender. They tend to get shorter in men quicker, and women tend to live longer. For those under 73, there's a really nice study showing that shorter telomeres correspond to about a slightly more than threefold increase in the risk of heart attack and stroke. And again, the shortening of telomeres is related to aging diseases through different mechanisms: oxidative stress, inflammation, cardiovascular disease progression. Next slide. Again, the rate at which telomeres shorten is accelerated by all the bad stuff, as well as some genetic disposition, other lifestyle habits. As you might imagine, heavy drinking, smoking, poor lifestyle choices that result in chronic inflammation will tend to, and of course, unfortunate things that result in inflammation, autoimmune diseases such as arthritis, Alzheimer's, neurological, all of those things tend to shorten telomeres. Telomere shortening has been associated with heart attacks, strokes, dementia, and cancer as well. Again, a few dozen thousand papers on this. So this image just shows a graphical representation of a patient's average telomere length compared to others in their age. We previously would compare their age cohort, give them percentile. We're working on getting that up and running again. The telomere score is based on the patient's telomere length in nucleated cells in their blood. And a higher telomere score here would suggest that their wear and tear is lower than their repair. It's certainly, if you look at that average line, that'll tell you how you're comparing to other people in your age cohort, and you want to be above average, right? Like we said, if you're under 70s, each kilobase, somebody is below average. Each 1,000 base pairs of telomere DNA, someone is below average. It slightly more than doubles their risk of heart attack and stroke, and it just gets worse with age. Luckily, it is addressable. Next slide, please. I think, as I mentioned, any number of health issues are associated with telomere shortening. Almost anyone you care to look at. Some of the more interesting ones is there are progeroid disorders where small children are aging at an accelerated rate. They don't usually live past 12 to 15, and they tend to suffer all these severe diseases of aging, glaucoma, hair loss, memory loss, and they also have foreshortened telomeres. But there are a wide range of health issues associated with telomere shortening. Basically, it's a really good proxy indicator for lots of overall health. Next slide, please. We also test MTHFR. It is tied to a lot of different pathways in the body. Through the urea cycle, there's a bit of waste breakdown. It is involved in the BH4 cycle, which impacts neurotransmitter synthesis, so energy, mood, sleepfulness. The folate cycle, where it makes glutathione, and which is a frontline that protects people from frontline environmental insults, as well as it reduces homocysteine and converts it into cysteine and glutathione. So if somebody has deficiencies in their MTHFR function, it's methylene tetrahydrofolate reductase, this sort of pathways aren't running as optimally as they can. And one of the things that can happen is hyperhomocystinemia. So someone can have intractable high homocysteine levels where they can benefit from methylated B6, B12, methylfolate to get that pathway moving a little bit better. This ties into both nutrition and cardiovascular disease health, and a nice addition to the other tests we're performing. Next slide. So again, the way it works is these are the two most common variants that have been identified, and the 1298 variants, and they interact to give you a sense of overall functional activity. And so in some cases, someone can have below 50% or 25% enzymatic activity, and that whole pathway will be running with poor function. And again, it can benefit from specific targeted supplementation. Next slide, please. Lots of things have been associated with MTHFR. You can go into PubMed, and they've associated these variants with hyperhomocystinemia, so cardiovascular disease risk, heart attack and stroke risk. It can, because B12 and folate are so important prenatally, it can be associated with fertility issues and pregnancy complications. So it's worth getting done. Through neurotransmitter production, it has been associated in some papers with depression and anxiety and cognitive decline. And this sort of makes sense. B12 is a kind of frontline. The bees play some frontline roles in stress support. And these days, it's hard to find people who aren't stressed out of their gourd and who couldn't benefit from B12 in general. It's one of the most common deficiencies, but people with this MTHFR variant will need it even more. And there are other health risks as well, thyroid dysfunction and some cancers. Next slide, please. SpectraCell has done any number of research collaboration with Texas A&M, with USC, with Stanford, with Rice back in the day, the Hypertension Institute at UT Austin, and others. So we are an ongoing process. We're always interested in getting more out there. We do have some papers, never enough, but we do have some publications on the technology and its applications. Finally, I'd like to thank you guys for your time. I hope this webinar helps you further understand what we're doing at SpectraCell and why it matters. Thank you so much.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.